So, hello everybody. My name is Dr. John Feldman. I'm from Hadassah Medical Center. I want to present our experience with the PQ system in our clinic, the Hadassah PQ Proton Center. You can see in the picture. This is a single volt upright position proton system, and it's based between Tel Aviv and Jerusalem in Israel. So let's show you what we've been doing over the last few months in this proton center. So what is the PQ system? The PQ system is a synchrotron-based accelerator which accelerates protons from 70 to 250 MeV. The field size at ISA center is 30 by 30 centimeters. The spot size, the sigma spot size, is between 2.5 to 7.5 millimeters. Obviously, the high energies have 2.5 millimeters. The low energies, the 70 MeV, has the 7.5 millimeters. In the room, we have an upright CT. It's over here, number 4. This upright CT allows us to do in the room 4D CT. In the room, we have 2 and 3 of the X-ray tubes and the X-ray panels that come up and down from the ceiling, which allow us to do KV daily. The system works IMPT, has a gated system built in. We've recently started the arc therapy on it. We have been treating offline adaptive, but in the future we'll be doing on the system online adaptive. Once research has compatible for us a system to do online adaptive, there's no problem in the system because we have a CT in the room. So it's not a cone beam CT, it's a normal Philips upright large bore CT. So the upright is by PQ, but it's a Philips large bore CT like in some of your simulators. We can treat either supine or seated or upright. This, as far as I know, is the most compact proton system on the market, and it can actually fit into a large accelerator vault without any construction. The proton radiotherapy system here, the synchrotron, by small adjustments, meaning making the ring a bit bigger, a new injector, will allow us in the future to do helium. So we'll be able to upgrade the system to a helium system, so we can choose in the future either proton or helium or both together. So what have we been doing up to now on the system? So we've treated over 20 patients. Our first patients were head and neck. Then we went on to cranial treatments. We had our first child treated on the system. Recently, we started lung, and the most recent thing we started is arc therapy on the first patient on arc therapy, which we're going to present to you today. So this is the child, our child treatment. He had a tumor to his eye, and he actually went through all the treatments without anesthesia. And this is due to him being in the upright system. He went through education beforehand, explaining what he's going to go through. He came and taught in the system with technicians and a teacher, an expert in teaching children going through this procedure, showing him all the stages. And therefore, he went through very happily through the treatment without any anesthesia at all. And we're quite a few months after, and he's disease-free. So we're very happy about that. Let's see his treatment, how his treatment goes along. So as mentioned before, he climbed up daily to the system. Not all patients climb up like he does, but this was his choice. He had a mask built for his face. As mentioned before, we have a CT in the room. So he daily was CT'd for 3D match. And this is the CT being built up. We'll see in a second the 3D to 3D match. This 3D reconstruction. And you can see how we're doing a match. It was easy because we can see the tumor both on the original CT and the second CT. The child is positioned in front of the beam. He has a camera in front of him, looking into his eye to make sure he's looking in the right direction. due to him moving between, we did a KV data in addition to the CT, the matches were fine. And during treatment, you'll see in a second, we're looking at the child's eye during treatment to make sure whilst beam is on, we told him through the speaker the beam's on, and he was told to look straight forward. And we knew if he moved his eyes sideways, the beam was stopped during treatment. Okay, so the second he moved his eye aside, we did beam off. And once he went through, we finished his treatment, had a nice talk with his father, and walked out of the room. Sorry. Well, what are our goals in the art therapy? First of all, to make sure it's visible. Second of all, to show our QA, how we did our QA. Positioning, the accuracy of the positioning, how comfortable the patient was. All these things are very important for us for the treatment. If the patient isn't sitting in a comfortable position, he won't get back to the same position. And I think in art therapy, it's even more important than in normal treatments and protons. So these are the angles. I'm going to show you the angles the patient can fit in. The beginning of this video, it's going to show the different parts we talked about. So we've got the chair, we have the upright CT, we have the beam. This is where the beam comes out, the nozzle. We have the X-ray panels. Behind here are the X-ray tubes. Panels come up and down. We have a laser, which we didn't need to use on the treatments because the system itself, based on the CT and the matching of CT, knows exactly where to position. And if we make sure we're in position with the KV images, so we're fine. So we didn't need the lasers at all. It's mainly used for phantoms and things like that. You can see the rotation of the chair allows us to do arcs on normal rotation. Usually the patients are planned with a 20 degree tilt. That's most comfortable for the patient. But some patients we treated with a 10 degree tilt. There was even a patient who we brought in completely upright. We have done 30 and 40 degrees tilts as well on different patients and the head and neck cases as well on some of the fields. You can see the chair has an opportunity either legs down or legs up. So this is legs down, legs up. And you can see it has much more flexibility in the rotations, much more angles than we have on our normal accelerators. Look at what we can do on the head and neck cases or on the cranial cases, especially. And you'll see, in addition to doing the normal rotations, we can now bring the patient into a supine position and rotate him in different directions and do different types of arcs. We can do an arc like this. We can do an arc like that. And we can do arcs between as well. We don't have to be in exactly this angle. We can be between. And we can change directions of movement of the chair into all different directions. Right. So as you can see, we have both three directions of arcs we can do in the basic directions, but we can do complex motions as well. And we can even do special shapes. And these are things I don't think anybody has checked what the effect of the quality of the plans will be if I start doing much more complex motions during the arcs. This is something that needs to be studied in the future. So our patient is a patient which is a recurrence. He was first diagnosed 12 years ago. He started radiation, first radiation was 2015, so 9 years ago. And over the last 9 years, he has had quite a few series of radiations to his chest and lungs. And we got to a situation where we wanted to find a new solution due to all the radiations already received. And therefore, it was chosen to go to proton therapy. He received 15 fractions of 3 gray. He's actually hasn't finished, but he's receiving 15 fractions of 3 gray. Comfort of positioning and accuracy of positioning. So we used the vac lock, and you can see he had special places to grip in the vac lock. Originally, we put special holders behind the chair for him to hold behind the chair. We x-rayed and did CTs of the patient holding this in different days, and we found he was moving, and it wasn't good enough for our proton treatments. The arm position was not keeping to position, and doing these vac locks with grips on the side was much more comfortable for him. We had on the vac lock holding his shoulder and elbow in position on both sides. You can see this. You can see here the motion of the patient. This patient has very, very little motion during the breathing cycle. But as you can see, this is the seated, this is the supine CT, this is the seated, the upright CT. The upright CT had even less movement. Okay, before we started treatment, we took a phantom, a body phantom, and we did quite a few plans on lung treatments on this phantom, and we compared the number of degrees or the number of fields, number of degrees between the fields or the number of fields treated, and we checked the effect on the different organs at risk and the PTV's targets. And the most important thing is we saw the time of treatment as we reduced the number of beamlets, or the number of beams per arc. We found the time went up. And actually, the shoulder of the movement was around 20 fields. Therefore, we chose for our treatment 19 fields. And this is what we're going to show you here. These are the 19 fields going around the patient on a half an arc. You can see them here again. This patient had two targets, one in the mediastinum and one in the lung. The lung target was much bigger. We used on the arc planning, we used a single isocenter, where on the when we did a non-arc, we used two fields per isocenter, one isocenter for this and one isocenter for this. We used MFO on the targets were drawn on as an ITV on a MIP CT, even though there was no movement. And we allowed in the arc per angle and 8 energy layers to reduce time. This is the arc plan, as you can see, compared to the two isocenter plan. And you can see very clearly some areas get higher dose, some areas get lower dose, as expected. But in total, if we look at the DVH, the arc plan had better coverage, a nicer shoulder. The lung was reduced, the esophagus was slightly reduced as well. So we were happier with the arc plan. We did QA measurements both on the arc check, which came out very nice on relative dosimetry and absolute dosimetry. We used a matrix, and with a 95% gamma index with 3 millimeters, we came out with a gamma index of 97.2%, which we were very happy with. And this is the treatment itself. So you're going to see the patient being positioned in the chair with the back lock we showed before, his grips, the arm grips at the bottom here, daily CT, first KV image, rotating round, halfway around, we stopped a second, did another KV, continued rotating. Actually, we did at least 3 KVs, one at the beginning, one midway, and one at the end. At the beginning, we did a few more, just to make sure we're in position as we're going along, and the patient was released from treatment. We did KV images, as mentioned before, at least 3 times during treatment. The movement was very minimal, it was less than 2 millimeters, more or less 1 millimeter, within 1 millimeter of movement. between the beamlets, between the KVs. We were very happy with this, and we didn't actually shift for them because we were happy with the results. We had combing, not combing, sorry, there's no combing on the system. We had full CT done before treatment and at the end of the treatment. We compared the beginning of the treatment and the end of the treatment. The positionings were always less than 3 millimeters, usually around 1.5, 2 millimeters. Time, how long does it take? So it didn't take that long, as long as expected. So per direction, it took us 45 seconds to give a beam. You have to remember, this is the first time we're doing this. The first patient, the system will get to lower numbers in the future. Rotating the patients between the angles was 10 seconds, and this was chosen just to avoid dizziness and reduce a lot from that. We chose 10 seconds to bring to minimum the feeling of the patient to rotating. So in total, the treatment of the patient, of the beam on and the rotation, was 17.2 minutes. The IGRT took an extra 10 minutes, so we were under 30 minutes, around 30 minutes of treatment. We were happy with this. The 2 ISA centers, due to the extra IGRTs that were needed, took longer. We just needed more CTs. In summary, we were happy with our results. We showed that it is feasible, both for the system and for the patient, to get these number of this ARC treatment. More patients will be done in the future. In the near future, hopefully, the plan, I think, is in the next few months working on dynamic ARC for the system, so not step and shoot. As mentioned, the next is building the dynamic ARC and getting more complex. So thank you very much to all our team on the Hadassah side. So these are the oncologists, the technicians, the therapists, and the nurses, the physicists, a very large team, psychiatrists, secretaries, and on the, it's only part of the team, there's more people actually. And this is the PQ team, a lot of people developing the system, sending it through the FDA. I even mentioned it, it's a full FDA system. So these are the people behind the system, the PQ system. Thanks to both teams. And it's been a real privilege working over the last few years with both of these teams. And thank you very much.